Good afternoon, everybody. This is Dr. David Jacobsohn, the Chief of Bone Marrow Transplant at Children's National, and I thank all of you for joining today. We have the way that the session is designed today is an introduction on pediatric bone marrow transplant, and then we will talk about transplant in the context of 3 diseases that we see fairly frequently here in our transplant program: acute lymphoblastic leukemia, sickle cell anemia, and neuroblastoma. And then at about 12:45 or so, we'll open this up for questions. Just a small introduction about our program. We are the only dedicated pediatric transplant program in the region, and we do about 50 transplants every year, and this is a combination of allogeneic and autologous transplants. Autologous transplants, these are some of the indications. Most typically, it's going to be for neuroblastoma and for brain tumors, although occasionally we will end up seeing some patients with sarcomas. And allogeneic transplants, we're most typically going to do for hematologic malignancies such as ALL and AML, and we'll spend quite a bit of time today talking about ALL. We see a few patients every year for a marrow failure syndrome such as aplastic anemia or Fanconi's anemia. Metabolic disorders such as Hurler syndrome can be helped by transplant, and hemoglobinopathies such as sickle cell anemia and beta thalassemia. And we'll spend quite a bit of time talking about sickle cell anemia. Very basically, what is a transplant? It's the process by which we restore bone marrow function, and that function could be absent by the disease process in a disease such as aplastic anemia, or by the ablation, which is what we typically do when we take a patient with leukemia to transplant. We give high doses of chemotherapy or radiation followed by the transplant. And to restore the function of hematopoiesis, we require a hematopoietic stem cell transplant that contains stem cells or cells that are CD34 positive and CD38 negative. Where do we get our stem cells for our patients? If patients have a HLA identical sibling, that's always going to be the first choice. That's always going to give you the lowest risk of complications such as graft versus host disease. In children, we typically collect those cells from the bone marrow, although there's other ways of collecting stem cells, such as a peripheral blood stem cell collection, which is done by giving GCSF to the donor and collecting the stem cells via a pheresis procedure. We can also use cells from unrelated donors, and these are typically going to be obtained from the National Marrow Donor Program. And we and other programs are also pioneering the use of haploidentical or half-matched transplants. And these would typically come from a half-matched sibling or from a parent. Of course, the risk here is severe graft versus host disease, but we do things such as T-cell depletion of the graft in order to prevent graft versus host disease. We can also get our stem cells from cord blood, and these are typically going to come from an unrelated cord blood bank. One of the benefits of cord blood is that it is rapidly available, so the cells are frozen in a bag, so theoretically you could do a transplant within really a week or two after deciding that a patient needs a transplant. So that's the benefit compared to an unrelated donor. One of the drawbacks is that these cells take a lot longer to engraft. So whereas an unrelated donor transplant achieves engraftment in about 20 days, this takes about 30 days to achieve engraftment with a cord blood donor. This is what a timeline for our patient typically looks like. On day 0, they get the infusion of a stem cell, and this looks very much like a transfusion, and it's generally very well tolerated. Before that, the patient undergoes the preparative chemotherapy, and we'll get into the reasons and rationale of how to choose the different preparative regimens in a few minutes. We watch the patients very, very carefully for the next month for infections, because the patients will have no white count for a few weeks, and the patients are under heavy doses of immunosuppression, so are at risk for infection. And once the cells start to engraft, which is about 20 to 30 days after transplant, we watch the patients very carefully for acute graft versus host disease, and we'll be talking about that in a minute. So conditioning regimens. How do we choose how intense the preparative regimen is before the transplant? Traditionally, all transplants were done with myeloablative preps, and these are the regimens on the left. So a lot of radiation or high doses of busulfan and cyclophosphamide. That traditionally was done to eradicate the leukemia, and then come in with the stem cells. It's become apparent that one can also get a graft in with getting lower doses of chemotherapy, so submyeloablative or immunoablative regimens. And the goal here is to give as least amount of chemotherapy to the patient, so as to not to cause harm, so as to not cause transplant-related morbidity such as mucositis, but enough to suppress the host so that the host doesn't reject the stem cells that are given on day 0. So you'll see that a lot of the transplants done nowadays, especially for non-malignant conditions where you don't need to eradicate a leukemia, you'll see that a lot of the transplants for non-malignant conditions are done with submyeloablative or immunoablative chemotherapy. HLA typing, the only thing I want to mention here is that there's a 25% chance for a sibling to be HLA identical to the patient. And so this is the first step, is typing all the children and the parents, and if there's no match, then we start looking at unrelated donors or unrelated cord blood donors. A little bit about the graft. Once we collect the cells from a sibling, or once we get cells from the National Marrow Donor Program from an unrelated donor, we may need to do some form of manipulation in the lab, and we have a very active stem cell processing lab, which may need to do red cell depletion if there's ABO mismatch, or in the case of a haploidentical transplant, in order to avoid graft versus host disease, we will need to do a T-cell depletion. This graph is just to show that the number of transplants in general continues increasing over the years, both related and unrelated transplants. So in terms of what we're trying to accomplish with allogeneic stem cell transplants is we want to achieve engraftment of donor marrow and have a balance between prevention of graft versus host disease and restoring normal immunity. So we want to achieve a level where we have enough immunosuppression so that we don't have graft versus host disease, and not too much immunosuppression so that we don't have infection. We also know that especially in leukemias, there's a very powerful graft versus leukemia effect. So it's not just the chemotherapy that plays a role, but it's the cells that play a role in eradicating the leukemia. So we want to be mindful and not give extremely high doses of immunosuppression after the transplant, because we want to allow that graft versus leukemia effect to take place. So we're really looking at a balance of graft versus host disease prevention, maintaining immunity so that we don't get severe infections, and allowing the graft versus leukemia effect to take place. Those are the main things we're doing in the few months post the allogeneic stem cell transplant. Just a brief primer on the most common complication after the allogeneic transplant. It's acute graft versus host disease, and this occurs from alloreactivity of donor cells against host tissues. And it's more common in the unrelated transplant setting. It can be seen in up to 50% of patients. And in the sibling, in the HLA identical sibling, it's seen in about 20 to 25% of patients. We can see graft versus host disease in the skin, and this is manifested by a rash. We can see it in the liver. It's manifested by elevation in bilirubin, and we can see it in the GI tract, and that's manifested mostly by abdominal pain and diarrhea. It's very important to confirm that this is what your patient has when you see these manifestations, because a lot of other conditions, such as viral infection or such as concomitant medications, could be causing these side effects. So typically, if the case is not straightforward, we'll get a liver biopsy, or we'll send our patient to an endoscopy to get a biopsy of the intestinal tract. And these are some pictures of what acute graft versus host disease of the skin would look like. We have a number of different preventative therapies. All of our patients get a calcineurin inhibitor, such as tacrolimus or cyclosporin. Typically, this goes on for 6 months, so maintained at pretty high levels for 100 days, and then weaned off from day 100 to day 180 in the absence of graft versus host disease. And a number of patients get some other forms of prevention depending on what protocols they are on. In terms of treatment, always the first line is going to be steroids. We know that steroids can be very good to treat graft versus host disease, but we also know that they have a lot of side effects, such as infectious complications, and long-term, a lot of issues with hypertension and growth. So really what the field is moving towards is trying to find a lot of steroid-sparing alternatives for prevention and treatment of graft versus host disease. And we're very active at Children's National with therapy such as photopheresis, trying to move this field forward. I now want to shift to talk about 3 different diseases that we transplant, and we'll start with the ALL, or acute lymphoblastic leukemia, which is the most common type of pediatric malignancies. We see about 3,000 cases per year, and most of the leukemias that we see in children are ALL, the rest are AML, and most of the ALLs are going to be B-cell ALL. Patients present, as most of you know, with anemia, thrombocytopenia, infections, and bony pain because of the leukemic blasts in the marrow, as can be seen on the left. And this is a Kaplan-Meier curve showing the excellent results of standard leukemia patients undergoing chemotherapy. And the main reason to show this is to tell you that most patients with ALL do not need a bone marrow transplant. Most patients with ALL can be cured with standard chemotherapy, and there's been dramatic improvements over the years because of patients being on Children's Oncology Group protocols. But there's about 10 or 20% of patients that are high risk for a variety of reasons, and we'll talk about those reasons in a minute. And those patients need to go to transplant to obtain a cure. This Kaplan-Meier curve shows us the outcomes that we can expect in patients undergoing transplant in first complete remission, about 50 to 60% long-term survival. Second complete remission, about 50% long-term survival. And for patients that are in CR3 or worse, we can still get some survival, and that's more in the 30% range. What are some of the factors that would make a patient in first remission go to need a transplant? As I mentioned before, about 90% of ALL patients will not go to transplant, will not need a transplant, as they can enjoy a long-term cure. But the goal is to identify which patients are high risk enough whereby we need to subject them to the risk of a transplant. So cytogenetic abnormalities, patients with Philadelphia positive chromosome ALL, patients with MLL translocation, which is the 411 translocation, usually these are infants, or patients with multiple cytogenetic abnormalities in their blasts. These are patients that have a high risk for relapse and are good transplant candidates. Also patients with that have a hypodiploidy. Young patients, generally patients under 1, or especially patients under 6 months of age, are ultra high risk patients. And patients that have either not achieved a complete remission by day 42 or have persistent minimal residual disease. These are going to be patients that are going to benefit from a bone marrow transplant. This is some work that we did in my prior institution in Chicago, looking at the 16 infants with ALL that underwent bone marrow transplant in first remission, showing a very excellent survival of 75% overall survival. The more common patients with ALL that we'll see in transplant are patients that relapse and then attain a second complete remission. And how do we decide which of these patients to get referred for transplant? They're typically going to be the patients that relapse earlier, with patients that relapse within 24 or 36 months after diagnosis are going to be higher risk patients and generally need a transplant to attain cure, as opposed to a patient that relapses, say, 4 or 5 years after diagnosis. These patients can sometimes be cured with additional chemotherapy and no transplant. We also know that a bone marrow relapse is worse than an extramedullary relapse, so patients that relapse in their CNS or just have a testicular relapse may do okay with additional chemotherapy, but patients with a bone marrow relapse only or with a combined relapse will generally need a transplant, especially if they relapse early in the under 2 or 3 year time period from diagnosis. And these are some slides comparing transplantation to chemotherapy in patients in second remission. This is data from many years ago, but the story is still quite similar in that we tend to get better long-term cures by taking CR2 patients to transplant rather than continuation of chemotherapy, and this effect is higher in the patients that have earlier relapse. What about patients that have relapsed multiple times or relapsed multiple times and cannot attain a remission? These patients are ones where we have difficult conversations with parents. These patients may not be able to attain a cure. There may be a very small likelihood that a transplant may benefit the patient, but we're now looking at the 10 or 20% likelihood of survival. So this is really where we're weighing benefit versus toxicity and considering whether something like palliation may be more appropriate for that family. What are the regimens that are typically considered for leukemia? They're traditionally going to be myeloablative regimens if the patient can tolerate these regimens. If the patient has a lot of pre-existing comorbid conditions such as issues with their heart or their lungs, we may consider a reduced intensity regimen. But if the patient can tolerate the high intensity regimens, then we generally can get better outcomes with this. And in ALL, it's going to be radiation-based regimen, so TBI and cyclophosphamide. We know that we're going to have short-term complications such as infections and graft versus host disease, and we know that there may be long-term issues that we will be dealing with in our long-term follow-up clinic, such as neurocognitive issues, which the radiation can cause, especially in young-term patients. I show here the rates of mortality from the transplant in the 10 to 30% range, although this is getting a lot better over time. And the last time we looked at our data, we're actually below 5% in the first 100 days after transplant. So transplant-related mortality has really improved in the last few years with all of our supportive care. In terms of stem cell sources for ALL, as I mentioned before, like with any other patient, we're going to prefer to do a sibling transplant if we can, because we're going to see a lot less graft versus host disease. But often, most patients are not going to have this as an option, so we'll look for unrelated donors or unrelated cord blood donors, and this will, what we choose will really depend on the size of the patient. So generally, younger patients are going to be better candidates for a cord blood transplant, and patients that need a transplant very quickly are going to benefit more from a cord blood transplant. These are some data from my old program in Chicago showing that really with excellent supportive care, we can obtain very similar survival with unrelated cord blood transplant as compared to allogeneic matched sibling transplant, so about 60% long-term survival for patients with pediatric ALL. I'd like to shift your attention now to another disease that we frequently deal with, which is sickle cell disease. This is something that we frequently see at Children's National and are paying a lot of attention to the therapy and to the cure of sickle cell disease. So typically, patients present with anemia, with severe repeated vaso-occlusive crisis that can really be debilitating. Some of the patients come in very frequently for narcotics. Patients can also present with acute chest syndrome, splenic sequestration, or stroke, which can be silent strokes and can often manifest with neurocognitive delays, or can be overt strokes. Generally, the treatment options are red blood cell transfusions, hydroxyurea. These would be maintenance options in patients, for example, that have had strokes or that have frequent pain crises, or as a definitive cure, hematopoietic stem cell transplant is one of the options. So what we're doing here is illustrated in this cartoon, where we are giving the transplant to a patient with sickle cell disease and are eradicating with the new graft, with the police or the new white cells, we're eradicating the sickled red cells. There's a lot of limitations, though, which is why we only transplant a fraction of sickle cell patients that are seen in this institution. While it remains the only cure for sickle cell disease, there's limitations because many patients don't have an appropriate donor. Remember that I told you that there's only a 25% chance that a sibling can match. The other limitations in these patients is that a number of the siblings may also be affected with sickle cell disease. And the other limitation is that the donor registry, the unrelated donor registry, is mostly made up of Caucasian individuals, making it much harder to find unrelated donor for patients in the African American community, to which most of our sickle cell patients belong. We also know that transplant outcomes are not as good for patients that have a pre-existing organ injury, so patients that have issues with their liver or their lungs. And a lot of patients with sickle cell disease are going to have these pre-existing conditions, making the likelihood of a successful transplant a little bit lower. So the idea here with the sickle cell disease field is to identify patients that do have some existing conditions, such as stroke or recurrent pain episodes or acute chest syndrome, and identify patients that are in a reasonable enough shape that they're not going to be harmed by the transplant. So it's really a balance here. We have been able to cure most of the patients that have come through for transplant for sickle cell disease in our program. There's a lot of excitement because of what I mentioned of patients having pre-existing comorbid conditions. There's a lot of excitement for very reduced intensity transplants or non-myeloablative transplant regimens. So really just giving minimal amounts of radiation or chemotherapy, just enough to get the graft in, and then maintaining patients with many years of immunosuppression, such as sirolimus, to maintain that tolerance of the graft. And this is really exciting data that was published a few years ago by the NIH group in the New England Journal of Medicine that looked at matched sibling transplants in adults with sickle cell disease using just one dose of radiation and a small dose of alemtuzumab or Campath, which targets T cells and NK cells, and followed by the transplant. So a very minimal regimen and very exciting. They saw that 9 out of 10 patients retained their graft, and most importantly, they didn't hurt any patients, and they've transplanted a number more patients since then. This is one of the patients that we successfully transplanted a number of years ago, who enjoys a complete cure. In summary, with these patients, we can cure about 95% of the patients that we transplant. The issue is that most kids with sickle cells survive, but when they reach adulthood, the mortality is high. So really, it's about trying to understand which are the kids that are likely going to have a severe disease phenotype and trying to transplant those kids early. I am very excited to tell you that we have recently embarked on a novel protocol using haploidentical or half-matched transplant for patients with very severe manifestations of sickle cell disease. And so far, the 2 patients that we have transplanted are doing very, very well. I now want to close the next few minutes with neuroblastoma, and I'm going to shift your thinking now from allogeneic to autologous transplant. So autologous transplant, it's really mainly the idea here is to collect stem cells from the patient themselves and freeze those stem cells and use them in the future, use them a few cycles later after a consolidative cycle of high-dose chemotherapy followed by the transplant. And really, the main thing we're doing here is rescuing the patient from the intensity of the chemotherapy. So neuroblastoma is by far the most typical disease that we're going to be doing an autologous transplant for, And there's been a lot of improvement in this disease over the last 30 plus years. Typically it was just chemotherapy and surgery, and for the last 2 decades or so, we have shown that bone marrow transplant, autologous bone marrow transplant, followed by local radiation, followed by Accutane, can improve the outcomes of patients with high-risk neuroblastoma. This is mostly going to be for your stage 4 neuroblastoma patients. Things that are being investigated these days are whether giving 2 transplants is better than 1, and the answer is that it is. So standard of care is now to get 2 autologous transplants, and there's also a lot of interest in hot MIBG, which is a radioactive, radio-labeled MIBG, which specifically targets the neuroblastoma cells. So this is a really nice slide showing the progress of work in autologous transplant for neuroblastoma. In the 80s, the field looked at whether allo versus auto transplant is better, and at that point it was determined that allogeneic doesn't really have much of a role. So we've been doing autologous transplant since then, and in the 90s showed that auto transplant versus continuation of chemotherapy provided an improvement in event-free survival. Then there was an interesting children's oncology group study that looked at whether purging of the graft for neuroblastoma, whether it improved the outcome, and it did not. And most recently reported in the last children's oncology group study, after a randomized study, did a 1 versus 2 transplant. It says here under analysis, but we have been able to show that 2 transplants are better than 1. And this is a Kaplan-Meier curve showing that here patients that were randomized to, this was a double randomization study, so patients were randomized to transplant versus no transplant, and retinoic acid versus no retinoic acid. And as you can see, patients that received both transplant and retinoic acid are enjoying about a 50% likelihood of event-free survival, which is a dramatic improvement compared to not using a transplant or retinoic acid. So this really shows what the impact of clinical, organized clinical trials has in our patients. We're almost at the time where we'll open this up for questions, but I'll share a little bit about the unit at Children's National. We recently renovated and increased our inpatient capacity from 8 to 11 units, and we have a very high-tech unit with positive pressure and HEPA filtered. We also have one room that we can convert to negative pressure as needed in case of patients with infectious diseases requiring that. And we are very proud of our nurses who are specialized specifically in bone marrow transplant. We can also do some things that a number of other floors cannot do to take care of our patients and to try to keep them on the floor as much as possible rather than going to the ICU. So things like continuous infusions, diuretics, is something that we can now do on our floor. I like to show this slide to really remember that to take care of the patients with ALL and with sickle cell disease and with neuroblastoma and all our other patients, it's really a team effort. It's not only the physicians and the nurse practitioners and the PAs, but also the nurses and the social workers, and we have a very committed group of child life specialists and art therapists and massage therapists that help take care of our kids and our families, because they are in the hospital for about 30 or 40 days actually. This is our new outpatient facility that is dedicated specifically to BMT. We see our patients about 3 times a week once they're discharged from the unit. And in conclusion, before we open it up for questions, this, by the way, is one of our patients that had a transplant for Philadelphia positive ALL. I mentioned this earlier. He had a 7 of 8 unrelated donor transplant about 6 months ago, and he is now back in college as a sophomore at the University of Michigan. So a real success story with a lot of advancements that we've talked about today. So in conclusion, there's a number of patients that cannot be cured with chemotherapy, a number of ALL patients that cannot be cured with chemotherapy that can be cured with allogeneic transplant, and these numbers have improved in the last decade. We can cure more than 90% of sickle cell patients with transplant, but that does not mean that every patient with sickle cell disease should have a transplant, because a number of patients with sickle cell disease patients do very well. In that disease, it's really about picking very high-risk patients that are going where the risk-benefit ratio makes sense to take them to transplant. In terms of neuroblastoma, we have shown that tandem autologous transplant improves their survival, and in general, especially for allogeneic transplant, both the preparative regimen and the cells play an important role. So there's an important graft versus leukemia role in transplant, and lack of sibling donor is no longer an option. We're very comfortable with unrelated donor transplants, cord blood transplants, as well as haploidentical transplants. So I'd like to stop there and thank everybody that has joined us, and we have time for a few questions if there are any. Do you want them, Tucker, to write in their questions or speak, or can they speak them up?
Writing in the questions works just fine, and then also if we do run out of time and anyone has questions, they can feel free to email those. I checked the email address that sent out the reminder about this, so if anyone just wants to respond to that with questions, they can. Just so everyone knows, after the presentation, we will send the recording of it as well as any other resources that Dr. Jacobsohn has to share with you all via email.
Thanks, Tucker.